This oration is awarded by Nephrology Forum of Nashik, and I take this privilege in bestowing Nashik Oration 2024 to Dr. Deepak Ray for his exemplary work in the ABO incompatible transplants and the management of ABMR in the ABO incompatible transplants. Over to you, sir.
Thank you. Thank you, chairpersons. Very, very kind words, and thank you, Nashik Forum, for this oration. I am really humbled by this. Thank you, Balwani. Okay, we have short time. I will straight go to the topic. Since 1960s, when this desensitization program had not developed well for ABO incompatible, even for ABO compatible ones, in a paper, they found that around 35% of ABOI kidney transplant never functioned because of hyperacute rejections, whereas only 5% of ABO compatible transplant had hyperacute rejections. Interestingly, 25% of them did function, and those who went beyond 3 months, they did as well as the ABO compatible transplant. So, at that time, we knew probably there is something to be done about desensitization and something like accommodation, even though it was not exactly known. There are 3 types of rejection which can happen in ABO incompatible transplant: hyperacute rejection, which happens within 24 hours, early acute rejection normally in 2 to 3 weeks time, and maybe maximum by a month, and beyond that the chronic rejections. I'll not go into the details, but hyperacute rejection almost doesn't happen in ABO incompatible transplant, provided you do a good desensitization. And that is because there are a lot of theories. One of the important theories is there are 2 types of antigens in the ABO incompatible transplant. One on the erythrocyte, and one which does the problem is the histoblood group antigen on the vascular endothelium. Now, if you have done a desensitization, there is not much of natural antibodies. So the antibody, since it is a carbohydrate antibody, takes around 2 days time to develop. So initial 2 days, you don't have hyperacute rejection, and initial 2 days are called as a silent or golden period. You don't have to bother. Other hypothesis I will not go because of the paucity of time. The early acute rejection happens after 2 days, up to 2 to 3 weeks till the accommodation develops. And this is because of the de novo antibodies formed after the transplantation to the endothelial antigens. And for the AMR, acute AMR, you don't need too much of antibodies. 10% of antibody that is required for a hyperacute is good enough to sensitize the complement activation and do the rejections. One important thing, unlike HLA, that initial antibody of ABO incompatible transplant before you start desensitizing has no bearing post-transplant, post-successful transplant. This, unlike HLA, DSS, even if you desensitize, there is a higher chance of AMR. This does not happen with the ABO incompatible transplant. So if you have sudden abrupt rise and with graft dysfunction, then you may think of ABO incompatible, ABO antibody related AMRs. Accommodation is well known for ABO in ABOIs. It takes around it starts from the very beginning, from the time of transplant, but takes around 2-3 weeks time to develop. And accommodation not only happens in ABO incompatible transplant, in very few ABO compatible ones there can be accommodation. In xenotransplantation there can be short-lived accommodations. And there are a lot of theories about it. I'm not again going into that because we'll have short time. But this accommodation helps in making the graft resistant to antibodies, resistant to rejections. That's a very good thing we get in ABO incompatible transplant. But this accommodation can be lost if there is very severe intercurrent infection or illness.
Sir, we have plenty of time, so there is no need to hurry.
Okay, thank you. Acute AMR happens either if desensitization has not been done properly because of natural antibodies, but since all of us do very good desensitization, it happens because of the de novo antibodies. And pre-transplant desensitization is very important. It actually reduces the AMR in ABO transplants. And post-transplant, we do monitor for 7-8 days till the patient is there in the hospital. But that antibody titer, if it goes up, we don't bother, but we look for the creatinine or the graft function. When there is a graft dysfunction, then only we act. Otherwise, we don't act because it can go up without causing any problem because of some partial accommodation by that time it has developed. The mechanisms are complement-mediated vascular thrombosis, antibody-dependent cellular toxicity, and direct signaling via binding to endothelial cell antigens. Anti-ABO antibody do not usually induce AMR after 3 weeks despite the titer rebound due to accommodation, as I have told earlier. The diagnosis will depend on the histopathology. You will have to have evidence of a tissue injury and microvascular injury, and you will have a high ABO titer, antibody titer, and a low or normal HLA-DSA. So then probably it is because of ABO incompatible transplant related AMR. Late AMR will happen if there has been an early acute AMR or if there is a non-compliance of immunosuppressants. It has been shown that if you keep the tacrolimus at around 7 all throughout the year and post 1 year for 5 years at around trough level of 5, there is less chance of their developing even chronic AMRs. It's an old study, but it's a good study. In South Korea, they did it in 2013, where they grouped into 4 groups. One is a control, which is ABO compatible without any HL antibodies. One is ABO incompatible. The third is ABO incompatible with HL antibodies, and fourth one with HLA antibodies. And they tried to find out prospectively what is the AMR rate. They found ABO transplant and controls, which are ABO compatible with no HL antibody, did much better than ABO incompatible with HLA or HLA itself. The strong baseline HLA-DSA was independent predictor of AMR, but not the baseline antibody titer. All 4 AMR in the ABO incompatible group, ABO incompatible with HLA antibodies, were because of HLA antibodies, because their ABO antibodies were normal. So, it is known, and all of us we have faced, that HLA antibodies are more immunogenic than the ABO incompatible ABO antibodies. Lower immunogenic nature of HL antibodies is compared with the anti-HL antibodies. That is because the blood group antigens in the ABO blood group antigens are carbohydrate with attached protein. They are less immunogenic, they are T-cell independent and naturally occurring. Whereas HL antibodies are proteinous in nature, more immunogenic, T-cell dependent, and it is also influenced by exposure like pregnancy, transfusion, and previous transplantation. ABO antibodies are not exposed to that kind of issues. Managing ABMR in ABO it remains same as HL antibody. We actually do not have any large-scale study or a prospective good study for even HL antibody treatment or ABMR because of DSA, HLA-DSA treatment. So whatever studies are there are small studies, mostly observational studies or individual experiences. So the initial treatment has to be antibody removal if it is ABOI or even HLA by plasmapheresis or immunoadsorption or and intravenous immunoglobulin. So we prefer plasmapheresis because it will also take out, if there is any HL antibody, it will also take out HL antibody. Immunoadsorption will only take out the ABO antibodies. Then anti-B cell therapy like mycophenolate and IVIG. Rituximab, since there are some centers where they don't use rituximab in ABO incompatible desensitization. In those centers, one need to use rituximab, but since we all usually use rituximab, maybe a low dose, we have in our study have seen that rituximab works for at least 2 years. The CD20 is low for 2 years, so probably there is no need of giving rituximab. And then of course, tacrolimus will be a better immunosuppressant than cyclosporine. And nowadays, eculizumab probably in some time it will be available in India, so there is a scope of eculizumab be used in certain cases. A good desensitization pre-transplant suppresses in ABOI, suppresses pre-sensitized B cells, clones and plasma cells, also suppresses processing of antigen recognition, development of de novo antibody production by host immune system. So a good desensitization will prevent AMR to a great extent. We know the role of IVIG, it neutralizes DSA, anti-idiotypic activity, inhibits complement activation by binding C3b, C4b, inhibits activation of macrophages, neutrophils and by binding to FCGRs, apoptosis of B cells. So IVIG is a good drug we use with plasma exchange. We started ABOI transplant in 2013 and we normally do around 30 a year. This year I think we will be doing more. And till we use a very simple and low cost protocol. We use rituximab 100 to 200 milligram 2 weeks prior to the transplant, 100 milligram if the antibody titer is 512 or less, 200 if it is more than 512. And we simultaneously start steroid 20 milligram per day, tacrolimus 0.1 milligram per kg, keeping the level as trough level as 9 to 12. Mycophenolate we give 1.5 gram. And 7 days prior to the expected date of surgery, we admit the patient, do plasma exchange. We do a low volume plasma exchange, 30 ml per kg, alternate day, and we replace with FFP that will prevent the bleeding during surgery, and that will also low cost, so that will help the cost, and followed by IVIG 5 gram. Presently, if our antibody titer is 64 for consecutive 2-3 days, then we go ahead and do the transplant. So your centers, if you are starting new, you can go up, down to 32. See, number of transplant we did in these years till end of last year is 283. We had 9 ABMRs, acute ABMRs. HLA related were 5, ABO related were 3, and one was ABO with HLA. We had 2 graft nephrectomy because they didn't respond to the therapy, one with the ABOI and one with ABOI and HLA. There is an interesting study which has shown in ABO incompatible transplant, in a longer term, the incidence of chronic AMR as well as the HLA antibody positive rates are low, 3.5% and 1.7%. Vis-a-vis in ABO compatible where it was 28.9% and 18.1%. This lower rate of chronic AMR could be due to B cell depletion of ABO incompatible transplants. I have a feeling the accommodation of ABO incompatible transplant also helps in the HLA lower rate of HLA related antibodies. We do see that, and in fact one of our DNBs has taken up that thesis, so shortly will come out with the result what exactly happens. There are studies showing that at 1 year the GFR of ABO incompatible are better than ABO compatible. At least we can consider both are equal. And it is known that de novo DSA and immune response to single antigen bead were reduced in ABO incompatible transplant because of rituximab. These are novel treatment which are being worked not for ABOI, it is for ABO compatible ones, but this will also work for ABO incompatible. If you see, the APC presents allo antigens present the yellow antigens to CD4 and T follicular helper cells, which is in the germinal center of the B cell. Then it goes to the naive B cell, where under the influence of IL-6 and IL-21, it develops into B memory cells, progress to plasma blasts, and ultimately antibody producing plasma cells. And then the antibodies are formed and they get attached to the antigens. This is a diagram. It is valid for HLA antibodies as well as ABO antibodies. There are drugs which act in different stages. Nowadays, people are trying to find out how to block it in every place. Like in the germinal center, the CTLA4 immunoglobulin or anti-CD28 will work. IL-6, IL-21 blockers will work here. Then we have daratumumab, which is a myeloma. It's an antibody for myeloma, MAB for myeloma, that works with the plasma cell. That's only work as plasma cell. Rituximab works at the B cells. Then again CTLA4 immunoglobulins and anti-CD28 work here. Proteasome inhibitors also work here. Then after antibody formation, then IDES can work. IDES is now available in the market in a commercial sense. It's very expensive. We know about rituximab. I will not get into that. Rituximab is a good drug for ABOI, and possibly that also prevents long-term chronic AMRs. The next version is obinutuzumab, which is stronger, and its B cell depletional activity is more. So it is being tried. Then co-stimulatory blockade like belatacept. Belatacept as less tried injectable drug. It's better than cyclosporine, but if it is compared with tacrolimus, it is probably equal. Then daratumumab, which is a drug people use for multiple myeloma, can be used. This is the drug which will work on the plasma cells. As you know, rituximab doesn't work on the plasma cells. Proteasome inhibitors like bortezomib has a questionable role. In larger studies, it has shown. Initially, people thought it will work well. So, but then the next generation is coming, carfilzomib, which may work. Then Bruton tyrosine kinase inhibitors like ibrutinib, IL-6 and IL-6 receptor inhibitors like tocilizumab and clazakizumab. Those are being tried as a prevention of chronic AMR. Of course, the eculizumab, a complement inhibitor. Eculizumab has been not tried in large studies, but there are small studies in ABO incompatible transplants. It has worked well. There are 2 case reports where AMR could be controlled with AMR with thrombotic microangiopathy could be treated with eculizumab. I last 2-3 months back, Professor Tanabe came to, I do a workshop on ABOI, and he had used in 2 cases with a low dose, not 900 milligram, 300 milligram. 300 milligram weekly he gave for 3 weeks, then 300 milligram fortnightly for 2 more doses, and they have done well. So cost is always a concern. It will be shortly available in India, so we need to know about it. And there is an open label study in Mayo Clinic where they tried eculizumab for prophylaxis in 26 highly sensitive patients, and they compared it with historical control with plasma exchanges. The long-term biopsies of eculizumab treated patients who remained DSA positive failed to show any difference in chronic AMR, but in acute cases it does work well. So maybe this will be a drug where we are suspecting the complement-related AMR, it can be used. Then IDES was initially tried in Sweden and USA. It worked in the USA limb but didn't work that well in Sweden. It's very expensive. The problem with it is that it does block the IgG, but again after some days IgG returns. But this may be tried also in very severe acute antibody-mediated rejections. I will end my talk with take-home message that ABMR in ABO transplant happens normally between 3 days to 3 weeks time. The treatment remains almost same as HL antibody-related AMR. The chronic ABMR and rise of HLA-DSA post-transplant is probably less common in ABO transplant as compared to ABO-compatible transplant. A good desensitization reduces the number of ABMR in ABO transplants and goes a long way. Rise of ABO antibodies not necessarily results in AMR post-transplant. So we don't actually, beyond discharge, after 8 days of transplant, we discharge, and we don't follow up with antibody titer by saving the cost. If they have a renal impairment, if the creatinine goes up, then only we test it. Thank you for a patient hearing.